So, initially we were fairly conservative because the average age of the patients in the Reactivate B trial was 47 years old. It was similar in the Reactivate A trial. We had 2 or 3 patients between ages 70 and 75 in the Reactivate B trial, and those 2 or 3 did quite well. But it still made us hesitant to recommend this therapy in that older patient group. Subsequently, thanks to the work of colleagues in Australia and Germany, we have a larger number of people in that older group. So we went ahead to look back at it and see essentially, were we being too conservative? And I think the answer is yes. So we looked at 2-year follow-up data on patients, and we had 29 patients who were less than 35 years old. You can see it on the screen here, and then 33 who were more than 60 years old. And then we looked at, in terms of Oswestry Disability Index, what percentage of the patients had a meaningful, a clinically meaningful difference, a 10-point or greater difference, and which percentage had a profound improvement on the Oswestry Disability Index, 20 points or greater. We looked at it for those 2 groups, the 35 and under and the 60 and over, essentially similar size groups. We did similar analyses in terms of pain. What percent of the patients were remitters with a pain score of less than 2.5, and what percentage were profound improvers with a 50% or greater improvement. And what we really found was the outcomes were not statistically different between the less than 35-year-old group and the over 60-year-old group. And we can look at these pie charts here showing, for example, if we say meaningful and profound Oswestry Disability Index improvement in the younger group, 72% and 62% respectively. What was it in the 60 and older group? 70% and 48%. That's, right. That's very analogous between the 2 groups. And it's when we look at pain, the older group actually did, ever so slightly better. 57% remitters and 57% profound responders in the younger group. In the older group, it was 58% and 64% who were remitters and profound responders. So this really showed us that we were essentially being too conservative in how we were looking at these older patients, and that we could feel quite confident in recommending them. The age group that we're talking about when we say we can feel confident is people between ages 65 and 75. And now that we're seeing these real world outcomes that really match the clinical trial, we can feel confident that in carefully selected older patients, we can get outcomes that are as good as what we get in younger patients. I would really say no, but I would put a couple of conditions on it. One, some of the older patients, you may not be able to do all of the physical exam maneuvers. The prone instability test, involves some movement, etc. So you might have to go more, say, with aberrant movements as opposed to prone instability test, depending on how the person's function is. And as people get older, of course, you're going to have a higher incidence of comorbidities of all sorts. So you're going to always screen people for comorbidities. You may find more in this population, but by and large, no, the process is the same. Refractory chronic low back pain that's mechanical or nociceptive, no prior surgery. It's not from the sacroiliac joint, et cetera, et cetera. Findings of multifidus dysfunction on physical exam and or imaging studies. All of that is the same for the older patients as it is for the younger patients. Yeah, I would say use the aberrant movement test as the physical exam test in that patient. Aberrant movements you can assess in essentially anybody. You just say, try to touch your toes. They don't have to succeed in touching their toes. And then you say, come back up. And you look for them having difficulty physically getting back up, maybe, pushing on their knees and legs to get back up. And you look at them having pain to get back up. So you can do that physical exam test on, anybody who can stand up, essentially. That would be my guidance. So looking at the imaging, for example, to make sure that there isn't an indication for surgery, an unstable spondylolisthesis or a high-grade spondylolisthesis. Looking for spinal stenosis. If there's severe spinal stenosis, I would hold off on that patient. And older people are going to, be somewhat more likely to have, or will be more likely to have severe stenosis. So, always make sure they don't have severe stenosis in the older patient, but also in the younger patient, if you saw severe stenosis, that would still be a similar concern. So all of that other workup, the standard workup for is this a good patient for reactivate therapy, is unchanged from that younger population to the older population. We're looking for those same things. You have pain when you do minor movements, brushing your teeth, washing dishes at the sink, maintaining a position for a prolonged period. Do you get relief with a brace or some kind of support? Do you feel like your back gets tired and is going to give out? All of those other things that we do when we're talking with the patient and or examining the patient are unchanged from the younger group to the older group. So certainly if they have symptomatic stenosis, with nerve root symptoms or neurogenic claudication symptoms, then this would not be a therapy for them. This is not going to decompress them. They're unlikely to do well. I would also say that a patient who has severe stenosis on imaging, not mild stenosis, not moderate stenosis, but severe stenosis of either the central canal or of the neuroforamens, even if that's asymptomatic, I would be hesitant to implant that patient because, excuse me, it may be asymptomatic right now, but I wouldn't be confident that it won't become symptomatic in the next few months. And again, that we would get a bad outcome in that patient. So I would avoid patients with severe stenosis, even if they were asymptomatic from it. No, just like a younger patient who had a prior lumbar surgery, an older patient with prior lumbar surgery, I would avoid for this therapy. So it's really the full range. For example, anything that would require an MRI, so multiple sclerosis, cancers, other neurologic conditions that are predictably going, or oncologic conditions that are going to predictably mean this patient is going to need to get regular MRIs. Right now, we don't have MRI conditionality yet, and we're also not certain of, will it be whole body or not. So I would avoid it. Any comorbidities that have with them the need to get an MRI. I would also just say others that are to the level of severity where the patient's not going to do well with this therapy or not going to do well tolerating it, severe pulmonary disease or cardiac disease. And then finally, some of the neurologic conditions would come to mind, severe peripheral neuropathy, et cetera. I would be assessing, on a case-by-case basis in those circumstances, but is that condition going to prevent the patient from getting a good outcome with this therapy? And if so, should we therefore not use this therapy in that patient? After all, we get great outcomes in appropriately selected patients. Let's stay with appropriate selection so we continue to get great outcomes. That will preserve this therapy for the patients who really need it. If we apply it to patients who are poorly selected, our outcomes will not be as good, and then we'll put the therapy in jeopardy. There may be more situations where a great outcome is being able to walk and do your shopping as opposed to being able to run a half marathon. Is being able to go to the pool and go for a nice swim as opposed to being able to do, vigorous mountain biking or horseback riding. But I think that's two things. One is that could also be true between two individuals who are the same age, right? For one younger person, it might be about being able to walk and stand for a prolonged period, do your work if your work involves walking and standing. Whereas for another person, it may be, half marathon. We've seen ultra marathons. As long as we're setting expectations with the patient, understanding from the patient, what is it that would be for you a home run success that would change your life and give you your life back? And then we achieve that. It's fine whether that thing is what would change my life would be being able to walk to the market and do my own shopping and live independently, or whether it's running a marathon would change my life, as long as we're matching it to the patient's expectations. And I would say the societal impacts, the economic impacts, in some cases for these older patients may start to be equally as important as they are with younger patients. Younger patients, you get somebody back to work, you get them off opioids, you get them fully functional, there's a huge economic implication of that. That person presumably has many years to live, and so the economic implication stretches over decades and adds up in an incredible way. But for an older patient, if it lets somebody continue to live independently rather than having to be in a nursing home or a care home, the implications of that economically can also be huge. And if it lets them keep walking so they can maintain their cardiovascular status, the implications, including economic as well as human implications of that, can be huge.